turn it over to Tiffany.
Hello. Thank you for having me back. It's so nice to see everyone again. It's so nice to be back here. Um, I'm going to talk to you today about a problem that is fortunately rare and we'd like to keep it rare. But when it does arise, it's very difficult to manage. So cervical cancer and pregnancy, and please feel free to interrupt at any point for questions. So learning objectives, just want to talk through the epidemiology, symptoms, the typical presentation of a cervical cancer in pregnancy, elucidate the means of preventing cervical cancer, explain some of the general considerations of treatment for these patients, and understand the treatment options based on stage and gestational age. Review the plan for long-term surveillance after treatment. So in terms of epidemiology, cancer in pregnancy, so not just cervical cancer, but all cancers in pregnancy, affect approximately 1 in 1,000 to 1 in 2,000 pregnancies. This does seem to be increased. The stats back in the 1960s were closer to 1 in 2,000. This is thought to reflect maybe the higher rates in cancer overall, but also that a lot of women are delaying childbearing until their third or fourth decades in certain societies, definitely in the US. The most common cancers that occur concurrent with pregnancy are heme malignancies, breast cancers, thyroid cancers, colon cancers, cervix, ovary, and melanomas. These are all just the same cancers that occur in women of reproductive ages. So the pregnancy itself is not a risk factor for developing these cancers. The pathologic features and prognosis of patients diagnosed during pregnancy are usually comparable with age and stage match non-pregnant patients. So that the pregnancy itself doesn't seem to confer overall worse outcome, thank goodness. One quick question that it's probably bothering some of you, but can the cancer spread to the fetus? Generally speaking, no. If you're going to have a test on your boards about a cancer spreading to the fetus, I want you to think about melanoma. That's really when it most often occurs. It could spread to the placenta and a little bit more rarely to the baby itself. There are very rare cases reported, 2 that I know of, where babies developed squamous cell lung cancers after delivering vaginally to moms with cervical squamous cell cancers. But really, generally speaking, cervical cancer doesn't pass to the baby. Again, generally speaking, treatment modalities of a cancer in pregnancy, you can consider surgery, you can consider chemotherapy, believe it or not. I know it probably sounds really scary to give chemo to a pregnant mom, but it is feasible and it is done and it is safe for both mom and baby, generally speaking. And then generally contraindicated in pregnancy is radiation. There are rare occurrences like of a thyroid cancer or another cancer far away from the abdomen where you can cautiously proceed with radiation and then you just shield the abdomen. But generally speaking, especially for a pelvic cancer, you wouldn't consider radiation unless the pregnancy was undesired. Hormone therapy is not really acceptable in pregnancy. Targeted therapy. So targeted therapy, in layman's terms, this is just sort of a specialized form of chemo. That's a little bit of a misnomer, but a targeted therapy is a drug that just works against a particular weakness or mutation within a cancer. Immunotherapy are, again, a lot of people will just combine this with chemo in their head because it usually goes in through an IV. But immunotherapy specifically is a drug that goes into your body and harnesses the power of your own immune system to kill the cancer. And very, very little is known. This is kind of a new class of medications. Very little is known about what the effects on a fetus would be. So this is generally not used in pregnancy. Cervical cancer and pregnancy, the unique concerns that go along with this, kind of the treatment dilemmas that go along with this. You want to ask yourself, is this pregnancy desired? I know that's a tough question to ask moms, but it's really important to get to the heart of that because that will impact all your treatment decisions. What is the gestational age at the time of diagnosis? Is this someone presenting at 8 weeks or is this someone presenting at 38 weeks? Because the management will be very different. And then you want to try to hurry up to find out what the stage of the cancer is during the pregnancy. You don't necessarily want to wait until after they deliver to start performing your workup of the cancer. And then you ask yourself, well, what would be the risk of delaying any treatment at all until after the baby's delivered? In some cases, the effect on prognosis would be very little. And then this is maybe a more second tier concern, but you want to look at the patient, talk to them. What are their desires for future fertility? Do they have concerns about future sexual function? When you're treating a patient who's 21 and this is her first pregnancy, she's going to have different kind of values or concerns as opposed to maybe a 45-year-old with 10 babies at home. So keeping those in mind as well. The reason I touched on that point is oftentimes cervical cancer can be treated kind of equally effectively when you catch it at an early stage with radical hysterectomy versus chemo and radiation. And those have very different side effect profiles. So chemo radiation causes a lot of fibrosis to the vaginal canal. A lot of sexual dysfunction can go along with that. It also, when you radiate the pelvis, you're putting them essentially directly into menopause. You kill the ovaries. The ovaries are very radiosensitive. And after usually 1 or 2 doses of radiation, remember you get daily doses for about 5 weeks for cervix cancer. After just a couple doses, their ovaries are essentially dead. So that has big implications for future babies, but also big implications for just their natural hormonal supply that keeps them through menopause, up until menopause. So what are the symptoms of a cervix cancer in pregnancy? The big takeaway I want you to get from this is essentially, usually, there are none. This is a diagnosis that's usually found incidentally, accidentally on a pap smear, a screening pap smear. Or perhaps the patient might have some subtle findings on the cervix that tip you off and lead you to a biopsy. Most will be early stage. That's a truth for the US. I don't know enough about Lesotho to know if that holds true here. Exam and recognition of the lesion can be really difficult in pregnancy because of all the natural changes that occur to the cervix. The atrophion is more pronounced in pregnancy. There's much more stromal edema, and there can be a decidual reaction of the cervix. So basically inducing what sort of looks like endometrium or placenta, thick, beefy red on the cervix, which can be normal. Decidual reaction is normal, but it can kind of mimic a tumor. If the patient's greater than stage 1B, and I'm going to go back over the staging here briefly in a second, then maybe they'll present with abnormal bleeding, pelvic pain, sciatica, flank pain, anemia, shortness of breath. Anyone in this room, can you look at that list? Maybe there's a woman in here who's ever been pregnant. Dr. Cabello. It might just be she and I, but can you look at this list and tell me what's wrong with this list? I'll tell you, as a lady who has been pregnant in her lifetime, you will feel all those things in pregnancy. You will bleed a little bit and you'll freak out, think you're miscarrying. You will have pelvic pain. You will have sciatica. You will probably get anemic, and you'll definitely be short of breath as that baby gets bigger. So really the take home here is cervical cancer in pregnancy is a silent disease. And if we're not screening pregnant ladies with pap smears, then we just won't catch them, or we'll catch them once it's too late. So this is a very busy slide. I apologize, but I want to just walk you through this here, how you stage cervix cancer. And I put this in as reference because a lot of the treatment will be dependent on the stage that you define for the patient. So generally speaking, a stage 1 cervix cancer is confined to the cervix. And that's true in almost all solid tumors. The stage 1 will mean it's confined to its organ of origin, if you're thinking about it simply. There are some subtle size criteria variations in that, but moving then down to a stage 2, that's when the cancer is now leaving the cervix and it's going either into the parametria, which are those filmy, lymphatic, kind of supportive structures holding the cervix in place, or it's extending down the vagina. And I always learned as a resident, when you have cervix cancer, you feel down and out, like you feel sad. That's how you remember stage 2. First it goes down, that's a stage 2A, then it goes out, that's a stage 2B. Stage 3 is once the cancer has now spread to lymph nodes. So this is going to be a locally advanced cervix cancer once it's in the lymph nodes of the pelvis, periaortic space. These patients are still curable. Once you get to stage 4, cure gets a lot more difficult. Stage 4A is the cancer is now growing into the bladder or the bowel. So it's involving solid organs in that region. I still think of these patients as curable. You need aggressive radiation and chemotherapy, but as long as the cancer is contained in the pelvis, I always think that we have a shot at cure. Once you get to stage 4B, that's cancer outside the pelvis. So that's a positive supraclavicular node, a positive inguinal lymph node. That doesn't count as being in the pelvis. Distant metastatic disease. Treatment for these patients is palliative, even really with the best care. Now, immunotherapy, which is really emerging as crucial in these HPV-driven diseases, immunotherapy can have some remarkable outcomes. I have a stage 4B cancer patient in the US that responded beautifully to chemoimmunotherapy. She's now 2.5 years in remission. But I keep telling her that it's most likely going to come back at some point and be lethal. So stage 4B disease, any treatment you offer that patient is palliative intent. So does anyone remember the difference between curative intent and palliative intent when it comes to cancer treatments? They're pretty much defined by their names, but curative intent, you can prepare that patient, hey, we have X amount of chance of curing this cancer. Palliative intent means we have no chance of making this cancer go away and you living a life without this cancer in the future. Any treatment we offer at this point will be to try to control it, control the symptoms from it, potentially prolong your life a little bit, give you some important time with your family, but we will never get you into remission or cancer-free in the long run. So how do you work up an abnormal pap smear in a pregnant lady? Who in this room, if you see an abnormal pap smear and you find out the woman's pregnant, who in this room thinks you should do nothing until they deliver? I think it's a really natural knee-jerk reaction to say, hey, she has an abnormal pap, but there's a pregnancy in there. Leave the cervix alone. You don't want to cause a miscarriage. You don't want to cause any complications. Leave her alone. We'll see her, 6 months from now when she's delivered. And when you have a low-grade change on pap smear, that's absolutely acceptable. The statistical chance that that will convert to a cancer during pregnancy is very, very low. But when you have high-grade changes on a pap smear, especially when it's early in pregnancy, I would really challenge you to start working that patient up, because there could already be cancer there and you could potentially cure this patient even while she's pregnant. And that would be my goal when I meet someone with that concern. So if you have high-grade changes on pap and the lady's pregnant, I would try to do a colposcopy or get cervical biopsies. Colposcopy is when you look at the cervix with a microscope so that you can take a better educated guess on where your biopsy should be. So when I say colposcopy here, just think cervical biopsies. Yeah. All right. When you do cervical biopsies, if you find low-grade changes and you really have a very low clinical concern for cancer, then you can watch these people. And if they're able to come back to you, I know sometimes patients coming back is hard, they don't have money for travel, but if they're able to come back to you, typically I recommend trying to look at the cervix once every trimester. So you look at them, they're 8 weeks old, they're 8 weeks along in their pregnancy, you get a CIN2 on a biopsy, you say, hey, why don't you come back to me in 3 to 6 months? Or why don't you let me look again? And you just kind of keep monitoring them through the pregnancy as much as the patient's able. You get biopsies back and there's a concern for microinvasion. So the pathologist might use language like HSIL or CIN3 or AIS, adenocarcinoma in situ, or cannot rule out invasion. They might use language like that on the path report saying they're concerned that something's worse is going on here. Or if your biopsies aren't correlating with what you're seeing clinically, you're like, yeah, this came back CIN3, but I feel like I was looking at a small tumor there. Then believe it or not, you should do a cone when they're pregnant, a cone biopsy of the cervix. You can safely do a cone. You can consider at that time placing a prophylactic cerclage as well. Two things that are really different in the pregnant patient versus non-pregnant is endocervical curettage. Remember, that's when you're kind of getting a sort of like a DNC or a curette, and you're grabbing cells from up high in the endocervical canal. We don't do that when someone's pregnant for very obvious reasons, just cause a miscarriage. And then also acceptable in a non-pregnant patient, if you have a high-grade change on a PAP, perhaps the patient has poor access to care, perhaps you're concerned you're never going to see them again. It is acceptable to take a non-pregnant lady with a high-grade PAP directly for a cone or a lead. Just saying statistically, I know something bad is probably there. Let's just treat it and get it off because she's going to disappear back to the districts. I'll never see her again. You don't actually want to do that if at all possible in pregnancy, though. If you're doing a cone in pregnancy, you want it to be for a very, very good reason. You want there to be something on exam or your biopsies that's saying, hey, there is a cancer lurking here. We need to do something about it now during these 6 to 9 months of pregnancy. So conization in pregnancy, who thinks it's absolutely insane to cut into a cervix in a pregnant lady? I do too. It's really scary. Nobody wants to do that. I want to do that. Poop in my pants every day when I have to do that. But this can be a life-saving procedure. You can, number one, it's diagnostic. You're finding a small cancer there that you didn't know was there. Now you can treat it appropriately. Number two, in a lot of cases, it's therapeutic. When you have a very small cancer, like a stage 1A1 cancer, 3 millimeters of cancer, oftentimes with the cone, you're curing them. Now, when I do cones in non-pregnant ladies, I'm aggressive, especially if their childbearing is complete. Get it all out of there. Get as much of that cervix out. Cure that patient. Make it so she never has to come back and see you ever again. When I do a cone in pregnancy, I'm very conservative. We'll talk a little bit about what a point means versus a cone. So in pregnant ladies, you're only doing a cone if, number one, the information from that cone would impact your timing or mode of delivery. Otherwise, postpone. So if there's a cancer there, would it impact your mode of delivery? Yes. Would it impact your timing of delivery? Yes, quite possibly, and we'll go into those. So when you have a high clinical suspicion for cancer, either based on biopsies or exam, please consider a cone in pregnancy. If the prepartum cone is necessary, it's preferred to do it in the early second trimester. You know, the miscarriage rate in first trimester naturally, even without a doctor going in there and cutting on a cervix, is naturally very high. So you want to wait till these pregnancies are well established. But you also want to, the further you go into pregnancy when you do a cone, the higher your blood loss can be expected to be. So it tends to be higher in the third trimester. And you definitely want to try to avoid a cone in the last 4 weeks of pregnancy, as labor can cause extension of that excision in the cervix and hemorrhage. Honestly, if it's the last 4 weeks of pregnancy, you're going to be delaying your work up until after delivery anyway. Complications of a cone in pregnancy, hemorrhage, fortunately is low-ish, depending on how you define low, 5 to 15%. Preterm labor, and I apologize, I used a lot of acronyms that we use in the States, so hopefully some of these make sense to you, but preterm labor, preterm premature rupture of membranes, and infection are risks. I just put in a little bit of the procedure of doing a cone and cerclage. Fortunately, I've only ever done this twice in my career. Again, as I said, highly nerve-wracking. Nobody enjoys cutting on a pregnant cervix. But the patient's in lithotomy, you want to do a good vaginal prep with soap to try to decrease the bacterial load. I do perform an injection of epinephrine circumferentially to cause some vasoconstriction and decrease blood supply just locally in that tissue. I use an estimate of the cervical length from a transvaginal ultrasound as close to the time of the procedure as possible, because I feel like with my 3D reasoning, I do such a better job if I kind of know how long the cervix is. And again, I'm not trying to cannulate the endocervix all the way up to those beautiful little membranes keeping that baby in there. So having an estimate from ultrasound first. I first place my hemostatic state sutures. When I do this in a non-pregnant patient, I always just place at 3 and 9 o'clock. And those give me traction to pull the cervix out towards me, but also they are kind of cutting off the blood supply a little bit to the cervix to decrease bleeding with the procedure. In a pregnant lady, I might actually place them also at 12 and 6 o'clock, just increasing hemostasis and increasing my kind of access to the cervix. And I do a cold knife cone in pregnancy, and I like to start with my blade at 6 o'clock and move anteriorly. The reason for that is quite simple. When you start cutting, the blood runs down, gravity, right? So if you start cutting at the top, the blood is going to run down the face of the cervix, making it more difficult to see. So start at 6 and move around. That is what I typically do. And then hemostasis, you use diathermy, you use Lugol solution, you use pressure. You might need to throw a stitch here or there to get stasis. If I'm placing a cerclage at the same time, and in the 2 patients I've done this, I have placed a cerclage both times. I use a McDonald's approach. I've never personally done a Sherrod car. I just don't know how to do them. So I do a simple McDonald. You can consider giving tocolytics or antibiotics. There's really no good data to support. I mean, this is such a rare surgery. It hasn't been that well studied, but there's not great data in cerclages for giving prophylactic tocolytics or antibiotics. But usually in these situations, you kind of feel like you want to do everything you possibly can to have the best pregnancy outcome. So I usually give antibiotics and some sort of tocolytic, like indomethacin or magnesium sulfate. I've done the cone first, obviously, so then I grasp the anterior and posterior lip with ring forceps, kind of more gentle on the tissue, and I pull towards myself. Use a really large caliber, non-absorbable suture, at least number 1 or 2. You can use braided or a monofilament, and then you just make first string suture circumferentially around the cervix 4 to 6. And I usually tie my knot at 6 o'clock on the cervix, although people have tried to study if it's better if you put your knot at 6 or 12. We haven't found any difference. And then you want to monitor the patient for a period of time for any signs of preterm labor or rupture of membranes. Here's some pictures for you to help you conceptualize. On the left, this is what a cone looks like. So it's called a cone because you're just taking a cone-shaped wedge of cervical tissue out. In pregnancy, I prefer to do something called a coin, and we call it that because it's just flatter. You don't go deeper up the endocervical canal. I stay very shallow with it. And physiologically, you're still getting good tissue. You're still potentially curing that because there's such an eversion of the endocervical canal naturally during pregnancy, and really just staying away from the membranes from the baby and not shortening the cervical length too much. Obviously, are big considerations in pregnancy. On the right, this is a very basic graphic of how you place a McDonald's cerclage. The photo on the top is a little, I think, misconstrued. It looks like the stitches are so superficial on the ectocervix. Remember, you want to be as high up on the endocervical canal as possible. You really want to be at the endocervical os with your cerclage if you can. So right where the kind of rugated vaginal wall meets the nice smooth cervix, that's where you want to try to put your stitch. So we talked about working up a dysplasia, an abnormal pap smear. Dysplasia just means precancer. But what if you have a frank cancer? What if you have a 2-centimeter tumor staring you in the face and you say, I know cervix cancer when I see it? Well, first do a really good exam. Your exam is the most important part of your staging. You want to be feeling on the cervix, on the vaginal walls, look at the vulva, feel in the groin, feel the parametria. Now, a parametrial exam really only is going to be possible in early pregnancy. When you have an enlarged gravid uterus in the 2nd, 3rd trimester, there is no parametria. There's just baby's head everywhere. You want to feel in the right upper quadrant. What are you looking for up here? What lives up here? The liver, right? So huge, enlarged, tender liver, a little bit more concerning for metastases, spread of the cancer. And then always feel their supraclavians. Just think of this as part of your oncologic pelvic exam. See, I listed under pelvic exam. So feel all the way up here. This is part of your pelvic. Labs, you want to get basic. Again, these are American acronyms, apologies, but I call it a CBC. That's hemoglobin, white blood cells, platelets. You want to look at their CMP, which is their kidney function, their liver function test. You want to get a type and screen if possible in these patients. They have a big cervix cancer. They're probably going to hemorrhage at some point. You're probably going to need blood available for them. So as you meet them and you have a clinical suspicion for cervix cancer, you might start preparing them to get their family to donate on their behalf. And then if they haven't already been tested recently, in the States, any new cervix cancer patient gets tested for HIV. And so also that should obviously be a consideration here. If you'll remember from my lecture last time, why is it important to test for HIV in a new cervix cancer? Well, cervix cancer is 99% of the time caused by HPV, another virus. So when you're immunosuppressed from HIV, your body just can't fight off HPV. And HPV is in the water, it's ubiquitous. When I tell people in the States that come to me with abnormal PAPs or early cervix cancers, they feel embarrassed, they feel ashamed. Say, listen, if you've ever had sex, you've been exposed to HPV. One partner, one time. Just think of it this way, you've been exposed to HPV. I think of it that way at least. This is just a reminder that tone cerclage is an important tactic to employ in select patients. Really, the standard of care when you have a new cervix cancer in early pregnancy in the first trimester is doing a surgical removal of lymph nodes in the pelvis. This will tell you the stage of the cancer. If these nodes are positive, it's a stage 3 cancer, and that's going to affect your management massively. Imaging, getting a chest X-ray is important. Looking for anything greater than for any cancer greater than microinvasive. So for anything greater than a 1A1, get a chest X-ray. Looking for mets. And if you have access to it, if you're able, an MRI without contrast is a safe imaging modality in pregnant patients. And it can really give a lot of information about the pelvic lymph nodes, about the tumor size, potentially can even estimate parametrial involvement depending on the gestational age. Now, everybody is really scared of CAT scans in pregnancy. And I agree, it's best to avoid them. We have an MRI machine here at QMMH. We should use that preferentially. But the safe or the tolerated amount of radiation in pregnancy is less than 5 rads. And if you add up a CT scan of the chest, abdomen, pelvis, you are under 5 rads. And 5 rads is much lower than really the acceptable dose in radiation. There's been no poor outcomes documented with a fetus less than 5 rads. So if necessary, a CT chest, abdomen, pelvis is actually without contrast is something that you can do in pregnancy. Treatment, I want to go back for a second. Prevention is the most important treatment. We don't ever want to be in a situation where we have 2 patients in one body suffering from cervix cancer, because that's what cervical cancer in pregnancy is. Now you have 2 individuals, innocent individuals, whose lives are held in the balance by one tumor. So prevention first. Remember, cervical cancer is a disease that is essentially completely preventable with HPV vaccination and adequate screening. Remember, undesired pregnancy is also pretty preventable. Modern birth control methods are great. Condoms, birth control pills. In the States, we call them LARCs, long-acting reversible contraception, like IUDs, or even permanent sterilization. Particularly in patients of reproductive age that have a precancer on the cervix, and you're talking to them about what next steps are, make sure they're on birth control. Even if they want a baby, say, hey, you have to put your family planning on hold until we take care of this problem on your cervix. So keep those 2 things linked in your mind. Abnormal pap smear, cervical precancer, make sure that they're on birth control. This is a really big pickle. This is a really big mess that we don't want to end up in. So now treatment of the cancer is going to be very dependent on stage, but also the gestational age. So is this early pregnancy or late pregnancy? In early pregnancy, if you have a stage 1A1, that means 3 millimeters of cancer. Number 1, you're going to have diagnosed that by doing a cone. Number 2, that cone was probably curative. So you're not going to do anything further until then they've delivered. A stage 1A2 to 1B1, remember the 1B1 is a gross tumor now. So 1A, you can't see the cancer. You can only measure it on biopsies. 1B, now you can see a tumor. And a 1B1 is going to be 2 centimeters or less. The risk of parametrial extension is less than 1%. So you can usually treat and cure these patients with conization. Stage 1B2, now we have a 2+ centimeter tumor up to a stage 2 with no evidence of lymph nodes on imaging or on lymphadenectomy, whatever you prefer to do. These can be treated with neoadjuvant chemotherapy. If they're not staged in pregnancy surgically with lymph node removal, then after delivery, you should perform a surgical staging possibly. If the patient presents with advanced stage positive lymph nodes, bowel bladder involvement, distant metastatic disease, lung nodules, liver nodules, if they're early and the pregnancy is undesired, termination and treatment would probably be the safest and most aggressive thing for the mother. If it's early and desired, then you want to go back to neoadjuvant chemotherapy, early delivery, and then definitive treatment after that, which would be a combination of chemotherapy and radiation. Now the baby presents and it's later in gestational age. Again, these stage 1A1s, even up to a 1B1 now, up to a 2 centimeter tumor, you meet them late in pregnancy, you can say, hey, we have a big problem here, but let's get the baby safely out and then go from there. 1B2 plus though, so now it's greater than a 2 centimeter tumor. It's not usually safe to wait. Their risk of metastasizing during that period of time is higher. And I would give these patients neoadjuvant chemotherapy. Remember, neoadjuvant just means giving chemo before you do any definitive therapy. So for these patients, definitive therapy would likely be radiation with a little bit of sensitizing chemo. So giving neoadjuvant in pregnancy first. And you want to be watching them. So you don't want to say, hey, all right, you have a 3 centimeter tumor. Let's give you chemo. Once the baby's out, we'll reassess and figure out what's going on then. Now, basically every cycle of chemo, you want to be repeating the pelvic exam. Are they responding? Are they progressing? If you can repeat an MRI, now getting one MRI in pregnancy is probably hard enough, but if it's been, 4 months, you can repeat an MRI, probably a good idea just to check back in, make sure that patient's at least having disease control. If you meet the patient with advanced stage, if it's undesired, termination and treatment. If it's desired, then neoadjuvant chemo and early delivery, kind of the same rubric. So giving chemotherapy in pregnancy, who's really scared of doing that in this room? Yeah, me too. Yeah, me too. It's not comfortable. But believe it or not, it can be life-saving for both mom and baby. We want that baby to be born, yes, but we want that baby to then be breastfed and then come home from school in 5th grade and see their mom there. And then graduate college and see their mom there. So sometimes it's necessary. You're going to give a platinum-based doublet, typically cisplatin and paclitaxel. You're going to do Q3-week dosing, max of 6 cycles in pregnancy. And you're typically going to proceed until gestational age 34 or 35 weeks. You want to stop at that time because if the patient goes into spontaneous labor, you want there have preferentially been a couple that has metabolized that chemo, got it out of the baby's body. And the baby's counts will go down the same way the mom's counts will go down in pregnancy. So you want to give 3 to 4 weeks to allow those counts to recover before they're delivered into this beautiful world full of germs, and they really, really, really need an immune system. If you are kind of forgetting, because I went through a lot of information and quite honestly, there is no strict guidelines for treating cervical cancer in pregnancy. It's always going to be a pot and you're going to throw in the gestational age, the stage, a bunch of other factors. You're going to stir it around. You're going to talk about it with the oncologist, with the OBGYNs, with the neonatologist. You're going to come up with the right answer for that patient in that setting. So there's really not a good way to write down, well, in this situation, do this, in that situation, do this. It always has to be individualized, and there always needs to be a team approach. But generally speaking, indications for immediate treatment, you meet a patient, she's pregnant, she has cervix cancer. If that cancer is progressing actively during pregnancy, you see her at 3 months and she has a 1 centimeter tumor. You see her then in the 2nd trimester, it's now a 2 to 3 centimeter tumor. It's time to treat. You obviously can't wait. It's proving that it's progressive. So progression during pregnancy, lymph node metastases, and if the patient chooses to terminate the pregnancy, obviously then you'd immediately start treatment. The mode of delivery, typically shorthand You have a cervix cancer in pregnancy, you're not going to let them deliver vaginally. This is going to be a cesarean delivery for obstetrics reasons, but also for fetal reasons. So generally speaking, there's a very high risk with a tumor in the cervix of there being obstructed labor, hemorrhage during labor. And there are some studies showing that it can potentially worsen the cancer outcomes as well. Potentially there's cancer spread into the lymphatic system during that process of ripening and dilation of the cervix. We're not exactly sure, but some studies suggest that it could affect cancer prognosis. The one exception is if you have one of those stage 1A patients, you've done a cone, they've healed, the margins on the cone were negative, you could potentially offer them a vaginal delivery. There are some documented cases of the cervix cancer recurring in an episiotomy line or with the line of an obstetric laceration. So you need to keep that in mind. You need to follow those patients and watch that area of their body, right? Kind of the vulval vaginal introitus, to make sure that they're not developing a hard, firm tumor at that site. So generally, shorthand, cervix cancer in pregnancy, they're going to be a cesarean. So then where do you pick up? So let's say you've had this patient, you've done workup, you've done some treatment during pregnancy, now they've delivered. And you're kind of like, okay, what do I do next? Let me remind myself here. Now you really want to ask yourself, does this patient want more babies? Or are they 42 and they have 10 at home and they're done? And they were like, whoa, that was a close call. I almost died. Please do whatever you need to do to make sure this is not a problem anymore. I need to go home and raise those 10 babies. So they don't desire future fertility. If you had a stage 1A, no lymphovascular space invasion, which is something the pathologist will comment on, I would offer them a simple hysterectomy. Just get the uterus out. You don't have to worry about a recurrence in the cervix in the future. If you had a stage 1A1 and there was cancer cells jumping into those lymphatic channels and the pathologist could see it and they wrote that on the report, or anything greater than that, then you want to consider radical hysterectomy. Now, you can do at the same moment a radical hysterectomy and a cesarean delivery. In the States, we usually call it a C-rad-hyst for short. That procedure comes with very high blood loss. So a radical hysterectomy in general, and a tiny non-pregnant uterus, you want to think 500 to a liter potentially of blood loss. Now you factor in this uterus is huge. The vessels going to it are massive. It's getting 500 cc's of blood per minute in the third trimester. You can expect 2 liters blood loss with a C-rad-hyst. So you need to have a lot of blood available. So I would often encourage that if you're planning a radical hysterectomy, deliver with cesarean, let the uterus involute, let those blood vessels get smaller, come back in 6 to 8 weeks and do your radical hysterectomy at that time. So a staged approach is generally much safer. Any patient who underwent neoadjuvant for locally advanced disease, meaning they have positive nodes or bladder bowel involvement, now, positive nodes, you can consider a radical hysterectomy with lymph node dissection. If they had advanced disease, so supraclav node, bowel bladder, then you're going to treat them as you would have prior, which is just with palliative intent, radiation and chemo. If they do have a desire for future fertility, you can only offer a fertility sparing technique in patients with up to a stage 1A2, so up to kind of a 2 to 4 centimeter tumor at diagnosis. And you better be confident that they had no nodes, their MRI is negative. Maybe you surgically stage them in the first trimester, but a 1A1, you can just follow them closely with pap smears. A 1A2, you can do something called a radical trachelectomy. That's when you do essentially a radical hysterectomy, but you only take the cervix and all the blood supply to the cervix. That is a more complex procedure. I've only done it twice myself in training and not for many years. But radical trachelectomy is a fertility sparing surgery that can be considered. If you have greater than a stage 1A2, they're just not a candidate for fertility sparing. It's unfortunate, it sucks. I never want to be the physician that's robbing someone of future babies. But I always tell people, can't get pregnant if you're dead. So we're trying to save your life from this cancer. I don't usually say it quite like that, but that is kind of the thought I've tried to get across to them. This I included, there's one review article on cervix cancer and pregnancy that tried to develop an algorithm to help you think through their stage, their gestational age, what your treatment options are. This is basically a very general rubric for you to look at and consider. But again, I would just really say that this requires individualized approach with a multidisciplinary team. So you need the peds team, you need the obs-gyn, you need oncology all working closely together on these cases. So after they're treated, you want to see them at, I guess, kind of whatever frequency you can offer and they're willing to come for, right? But I think an annual piece, you're looking for weight loss, you're looking for new back pain, you're looking for new ankle swelling, you're looking for vaginal bleeding. Weight loss, any metastatic cancer is going to cause sort of metabolic shifts that cause the patient to lose weight and have a lower appetite. New back pain, that makes me concerned for bony mets, but also large lymph nodes pressing on certain nerves that can kind of trigger back pain. Lower extremity edema, also think adenopathy, big boombas of lymph nodes pushing against veins. Now the blood supply, the blood return from the lower extremities is compromised. Vaginal bleeding, it can occur right at the top of the vagina, or if the cervix is still in situ in the cervix. Want to do a pelvic exam, look at the vulva, the vagina, the cervix if present, the groins, the right upper quadrant, the supraclavians. And why would you do a pap smear in someone after they've been treated for cervical cancer? Well, because HPV is a virus that colonizes the lower genital tract, the vagina, the vulva, the anus. And taking a pap smear of the vagina you can grab dysplasia or precancer. This is essentially now a new problem. So you've treated the cervix cancer, HPV is still in their body, and it's still trying to kill them. Still trying to give them a vaginal cancer or a vulvar cancer. I have a patient in my practice with Sjogren's disease, and she takes steroids every day, so she's immunosuppressed. I've cured her of both a cervix cancer and a vulvar cancer. I'm not saying that's pat myself on the back. I'm saying it more. Can you imagine how frustrating it is for that patient that she went through chemo radiation for cervix cancer just to turn around and get a vulvar cancer and need more treatments? It's very, very frustrating. It's a very gnarly virus. That's it, guys. I think I'm out of time, but if anyone has a brief question, I will do my best not to cry and find an answer.